This is part 4 of the Depressive Disorders and Bipolar Disorder chapter recap of the PMHNP Review and Resource Manual 4th edition. We'll start with non-pharmacological management and electroconvulsive therapy, or ECT, which is a grand mal seizure induced in a person under general anesthesia. The usual course is 6 to 12 treatments. The mechanism of action of ECT, there's 3 different theories. The neurotransmitter theory is that there's increases in dopamine and serotonin, and norepinephrine. The neuroendocrine theory is that there's releases of hormones such as prolactin, thyroid stimulating hormone, pituitary hormones, endorphins, and adrenocorticotropic hormone. The anticonvulsant theory exerts an anticonvulsant effect, which then produces an antidepressant effect. Situations in which ECT is used is client preference, the need for rapid response because of severity of illness, major depressive disorder with psychotic features, risk of other treatment outweighs the risk of ECT, and for treatment-resistant depression. Possible contraindications are cardiac disease, compromised pulmonary status, history of brain injury or brain tumor, and anesthesia or medical complication history. Adverse effects of ECT are possible cardiovascular effects, systemic effects such as headache, muscle aches, and drowsiness, and cognitive effects such as memory disturbances and confusion. Now we'll move on to transcranial magnetic stimulation, or TMS. This is an option for clients who have not had adequate response to medications and psychotherapy, such as with treatment-resistant depression. TMS involves placement of a small wire coil on the scalp to conduct an electrical current, creating a magnetic field through the tissue of the head. It's performed in office setting without anesthesia, and the sessions typically last 40 minutes, and typical course is 5 sessions per week for about 6 weeks. The side effects of TMS are minimal but may include a headache, scalp discomfort, tingling, or twitches to facial muscles, lightheadedness, and hearing discomfort from the procedure noise, and seizures, although rare, have been reported. Now we'll talk about vagal nerve stimulation, or VNS. This is an option for clients who have not had adequate response to medications and psychotherapy, such as with treatment-resistant depression. This is a pacemaker-like device implanted in the left side of the chest to stimulate left branch of nerve. Transcutaneous devices are being tested. Well, this was written in 2012, so maybe we've made progress. It's generally done as an outpatient procedure, but anesthesia is required. Side effects generally occur as the pulse generator stimulates the vagal nerve and include voice changes, hoarseness, cough, throat or neck pain, chest spasms, dyspnea on exertion, tingling of the skin, and dysphagia. It's intended for use along with traditional treatments. Phototherapy is 2,500 to 10,000 lux light for 30 minutes up to 2 hours, 1 to 2 times daily. And that's all the book says about that. After phototherapy, what is in the book is individual therapy, brief therapy, solution-focused group therapy, and family therapy regarding what is recommended for major depressive disorder. And I'm going to skip that section and move on to clinical management of suicidality. So pay significant attention to the positive assessments for suicidality. Always assume that the client is serious when he or she vocalizes suicidal thoughts. Identify current stressors that may be contributing to the crisis. This is generally not managed in a community setting, but during acute suicidal ideation periods, unless the client is able to make a no-harm agreement, consider hospitalization and consider mobilizing available social resources. And the no-harm agreement, I believe, is no longer evidence-based intervention, but it's still listed here. Risk factors for suicide. I'll just list them off. So age 45 or older if male, age 55 or older if female, divorced, single, or separated, white, race, living alone, having a psychiatric disorder or a physical illness, substance abuse, previous suicide attempts or attempt, family history of suicide, a recent loss, and male gender are all risk factors. Lifespan considerations. Children. Core symptoms of major depressive disorder are the same for children. However, some symptoms are more pronounced in children, such as irritability, somatic complaints, and social withdrawal. Some core symptoms are less common in children before the onset of puberty, such as psychosis, motor retardation, hypersomnia, and increased appetite. So these are less common in children before the onset of puberty. Major depressive disorder often has a strong separation anxiety component in children. Children usually do not respond well to tricyclics. However, they do respond well to SSRIs. Keep in mind that all antidepressants indicated for children and adolescents and young adults carry a black box warning about an increase in suicidal thoughts. So monitor closely for suicidal thoughts, behavior, agitation, and aggression in children taking antidepressants. Lifespan considerations. Older adults. Persons with major depressive disorder admitted to a long-term care facility have significantly shorter lifespans than the controlled population. 65% are more likely to die within the first year in a long-term care facility. Cognition and memory symptoms of major depressive disorder in older adult population are often confused with dementia-related symptoms, often called pseudodementia. Clients with dementia usually have a premorbid history of slowly declining cognition, but in major depressive disorder, the cognitive changes have a relatively acute onset and are significant when compared to premorbid functioning. It is important to complete a functional assessment for older adults to determine the degree to which the person's abilities and performance match the demands of his or her life, and it determines the impact of illness on overall functioning. Skill deficit is an inability to perform a functional skill despite the physical ability to do so, such as in dementia. That's a skill deficit is seen in dementia. Performance deficit is seen in depression. It's the ability to perform a functional skill but lacking the motivation to do so, and as we see in depression. Reasons for performing a functional assessment are to correctly diagnose, for example, to differentiate depression from dementia, to track the client improvement or decompensation, and to help families set realistic expectations. And these are the reasons to perform a functional assessment. Activities of daily living are ADLs. This is basic self-care skills such as bathing, dressing, and eating. Instrumental activities of daily living are complex activities needed for independent functioning, and executive functioning are judgment and planning. So, just to recap again, activities of daily living are basic self-care skills such as bathing, dressing, eating, and toileting. That's activities of daily living or ADLs. Instrumental activities of daily living or IADLs are complex activities needed for independent functioning such as shopping, cooking, driving, and housekeeping. Executive functioning is judgment and planning, the ability to maintain a calendar, manage money and appointments, and prioritize activities. The degree of change over time and the speed of change are better observed with objective recording and when the assessment is measured at intervals such as every 6 months. Follow-up care practices for the PMHNP to consider include teaching the client the goals, risks, benefits, and potential side effects of medication treatment. Continuously monitor clients' response to medication. The treatment goal is complete remission of symptoms. Utilize screening tools such as the PHQ-9 in follow-up appointments. Teach clients the symptoms of depression and that it is a chronic illness. Establish a relapse plan for all clients. Assess for suicidality during every visit, along with psychotic symptoms during every client contact, and side effects of treatment, including sexual side effects, in an attempt to increase medication compliance, and observe all clients treated with antidepressants for development of serotonin syndrome, which is overstimulation of serotonin receptors usually caused by drug-drug interactions. Drug combinations that can cause serotonin syndrome are SSRIs combined with MAOIs, or drug and herbal interactions, or SSRIs combined with St. John's wort. Some symptoms of serotonin syndrome are listed in the slide, but I'll go ahead and list everything that is here. So autonomic instability, altered sensorium, restlessness, agitation, myoclonus, hyperreflexia, hyperthermia, diaphoresis, tremor, chills, diarrhea, and cramps, ataxia, headache, and insomnia. Monitor for adverse effects over time. Some SSRIs are known to increase blood glucose and to contribute to hyperlipidemia, and others may elevate liver function tests. Discontinue SSRIs slowly to prevent discontinuation syndrome or withdrawal. Symptoms of discontinuation syndrome are flu-like symptoms due to the cholinergic rebound, particularly problematic with TCAs, fatigue and lethargy, myalgia, decreased concentration, nausea and vomiting, impaired memory, paresthesias including shock-like sensations, usually that is with SNRIs, I believe, irritability, anxiety, insomnia, crying without provocation, and dizziness and vertigo. Risk factors for discontinuation syndrome are medications with short half-life, abrupt discontinuation, non-compliant or irregular pattern use, high dose range, long-term treatment, and prior history of discontinuation syndrome. The expected course for major depressive disorder is evidence indicates the best treatment outcomes are if medications are used in conjunction with appropriate therapy. Evidence indicates also that clients should take antidepressive agents for at least 12 months after the resolution of symptoms. And clients who have had 3 or more episodes of major depressive disorder usually require lifelong medication treatment. I'll stop here for part 4 and wrap up the chapter with part 5. And so the last chapter, or the last part, will contain persistent depressive disorder, premenstrual dysphoric disorder, bipolar, cyclothymic disorder, and medications specific to these disease processes.